Welcome to our discussion about reimagining provider networks and care delivery. Over the past few years, we've seen the emergence of new and novel care models that blend people and technology in new ways to provide members with personalized options to manage their health and healthcare. In response, health plans are innovating their networks across preventive, chronic, and catastrophic care with new primary and specialty care models, so they can align population risk and address barriers to access and affordability. This panel will explore the emergence of these new high-performance networks and will also examine health plan perspectives on creating closer payer-provider partnerships and alliances as part of these strategies. My name is Brian Callis with Accenture's Health Practice, and I'll be moderating today's discussion. Today, I'm honored to be joined by our panelists for the discussion as well. Let's begin with introductions, starting with Sonal.
Thank you, Brian. Sonal Kathuria. Similar to Brian, I'm a managing director in our Accenture Health Strategy practice, where I lead strategy for health payers. And Brian, as you know really well, I spend a lot of time with my clients working on care delivery innovation, value-based care, and affordability issues. Very excited about the panel and very excited to be here. So thank you for having me.
Thanks, Sonal. Toyin, go next.
Hi there. My name is Toyin Ajayi. I'm a primary care physician and the chief health officer and the co-founder of an organization called Cityblock Health. We are a provider organization that delivers integrated primary care, behavioral health, and social services to primarily high risk and rising risk populations of folks who are insured typically under Medicare, Medicaid, or dually eligible for Medicare and Medicaid. I'm really delighted to be here with you.
Great. Thanks, Toyin. And Mark.
Thanks, Brian. Always impossible to follow Toyin, but I'll do my best here. So I'm Mark Margiotta from Tufts Health Plan. I'll give you just a quick few points that I think will help color some of my comments today. So I work at Tufts Health Plan, which is a 1.1 million member plan serving Massachusetts, Rhode Island, and New Hampshire. We have insurance offerings across really all product lines, but the focus of today's discussion will be our what we call our public plans division. So we're the largest Medicaid, MCO, and ACO issuer in Massachusetts. We're the largest QHP or individual market issuer in Massachusetts. And we're also one of two plans offering an under 65 duals offering, which is called OneCare, and it's an MMP in Massachusetts. My role is specifically to oversee two of those business lines. So the individual or QHP business, as well as the under 65 duals product, which will be the focus of what we talk about today. And just for a little bit of context, we work with Cityblock in sort of two ways. The first is we have a capitated arrangement with Cityblock for a subset of our population in the under 65 duals product, and that's launched earlier this year. And more recently, we launched a sort of a rapid response fee-for-service based program with Cityblock that expands beyond just our under 65 duals population to both our MCO book and our individual market book. So just wanted to give those points of context that'll provide a little bit of color as my commentary for my commentary in this panel. But excited to be here. Thanks, Brian.
Great. Thanks, Mark. So let's begin and dive in with looking at the current state. Sonal, as a starter, how would you describe, what the current state is of reimagining provider networks, and how do you see new primary and specialty care models fitting into those emerging networks?
Brian, I'm glad you asked me this question because I do think with COVID, many of those reimagining opportunities have really been accentuated, right? Like we're seeing across in healthcare. So let me just frame a few things for you all as what has transpired, right? When you look at COVID and you look at typical payer networks, what's being done? Out of state needs to be the same as in state. When access needs to be same for virtual and face-to-face. We're in a situation where medical, behavioral, pharmacy issues are all bound up in one. So what does that network mean, right? When retail needs to be shifted to mail, and hospitals when they can't see someone, and care really needs to be virtual. So networks really need to be thought through with that lens. And some would say some parts of network are at risk, right? There's potential volatility with what's going on with the economy and furloughs and just this postponement of electives. So it's a very interesting time because, as we all know, traditional health plan networks are built upon unit cost negotiation, period, full stop, right? Blues have a better chance of being able to negotiate that unit cost. Nationals is different, and that's sort of how it's been across hospital networks, across specialist network, across primary care. So, and then what's also happening with COVID and even outside of COVID is the growing use of health-related digital technologies. So now you have scheduling applications. There's tools available, and there's regulatory reasons where you need to be able to convey both the cost and quality of transparency of data and services that you want to be able to utilize. There's virtual visits, obviously, that have gone up, 60 to 80% with, physicians. A big proportion of that is mental health, et cetera. So could eventually these tools give consumers ability to create their own hyper narrow networks? So this level of what we've been calling in our practice, as you know, is atomization of provider network is very telling. So the challenge for reimagining networks for payers definitely going to be is how do they use networks as a vehicle to right size and align care, where primary care is brought in as this hub to be able to orchestrate that care, and then they can really align care across special home hospitals. So I think that's the challenge and the opportunity.
Great. Thanks, Sonal. So now flipping it a bit, Toyin, more to the new primary care models and maybe building off what Sonal mentioned. Toyin, what are you seeing as just some of the need and the innovation in new primary care models generally? And specifically, can you share more about the CityBlock model and what led you to creating CityBlock in the first place?
Yeah, absolutely. Thank you. So just maybe a little bit of background into how kind of I got into this work. Prior to co-founding CityBlock, I was the chief medical officer at a health plan, also in Massachusetts, Commonwealth Care Alliance, that focused specifically on caring for and ensuring folks who are dually eligible for Medicare and Medicaid across the age spectrum. And from the vantage point of a payer, my experience really, I think, lent itself very much to the inspiration for CityBlock, which is that we found as a payer that as you contract a network of primary care providers, many of whom have panels of some of your highest risk, most complex, most high need, highest utilizing individuals, that sort of, typical 10% that drives up to 60% of spend for across any book of business. What we found was that most primary care providers were not equipped to fully own and deliver across the value proposition for the member and for the plan, which is that we were trying to push to risk. And the goal here is to fully align incentives, and that a lot of providers didn't have the infrastructure or the technology or the data or the field-based care management capabilities to effectively manage that risk and to effectively then integrate care. And so what we were doing was essentially creating care management from the health plan perspective and trying our best to wrap around a pretty heterogeneous provider network where the providers had very different capability sets, did not have the focus necessarily or the orientation to deliver what the members needed. And that for me was a huge part of the impetus to found CityBlock. I'm a primary care provider. I continue to see patients. I'm deeply passionate about the idea that primary care physicians and providers in practice in the community are best positioned to deliver on what their populations need, are best positioned to understand not just the physical health, but also the behavioral health and the social drivers of poor outcomes, and are best positioned to hold and then deliver alongside that longitudinal trusted relationship with that member. And that if we can equip our primary care providers in the network and in the community with the tools, with the data, with the analytics and the infrastructure, we'd actually get the outcomes that we're looking for, that we're hoping for those folks who need us the most and who have the highest and most significant needs. And so what that meant for us was creating a business that is built for risk relationships with payers, that is oriented around populations with the greatest needs, that are very frequently not the populations that most venture-backed startups in the health tech space go after, but that actually have a huge amount of opportunity, that is oriented around delivering primary care, behavioral health, and social care, both as a primary care provider itself, but also in partnership with existing providers within a payer's network, really helping to reinforce and bolster the infrastructure around those members of greatest need. And what we've seen is that this is part of an ongoing trend. We've seen massive tailwinds in states and CMS really pushing and creating opportunities for payers to push risk to providers, to deliver on what we know works from a field-based care management, care coordination perspective, to fund both medical and non-medical and social needs, as well as deliver on the physical health and behavioral health needs of a population, and to bring it all together in one service offering. And so that has been our model, and that has been the genesis of our model. Is contextualized within, I think, a broader impetus to move towards these types of innovations.
Great. No, thanks, Toyin. And I think now with that, let's kind of dive into a bit of how's that working, and how are you seeing some of those collaborations with some of the other payer partners you have in the network. Mark, we'll go to you with that, and kind of, what has Tufts been doing to reimagine its provider networks, and how do new primary and specialty care models fit into those strategies? Specifically the CityBlock relationship you mentioned in your intro.
Sure. It's funny listening to Toyin talk about the founding of CityBlock, because in many ways the challenges that she experienced in her prior role are the same challenges that we were coming up against in our under 65 duals product, and led us to the relationship that we have today. So I'll give a little bit more context. Very similar themes to Toyin, which you hit on, but just from a pure payer perspective. So Tufts Health Plan was traditionally a commercial payer. We've since grown into the public plan space through acquisitions and new product launches. And so at its core, though, as a plan, we view our job is to connect members with the providers that are most appropriately resourced and to serve them. And so trying to create those connections. And as we move more and more towards specialized product lines and specialized communities within our markets, trying to match those together brings more and more challenges. I think the hyper narrow network, Sonal, that you mentioned is a concept that's out there. It's even more challenging, I would say, for the under 65 duals populations and duals populations in general, where so much of those networks are about care pathways and really a clinical lens. So as we're trying to solve for these more specialized populations, we're finding ourselves having to blur the lines between what's a traditional plan role, what's a traditional care management role, what's a traditional provider role, because we don't really fit in those silos anymore to actually deliver care or deliver networks for our members that work for them. And so we're trying to step back and say, what are the gaps that exist? And let's solve for those gaps, and let's throw out some of the old norms that exist about what a payer is supposed to do, what a provider is supposed to do. So for CityBlock in particular, for our under 65 duals product, our approach was pretty similar to what Toyin mentioned, what you mentioned, which is we have an internal care management staff that is really trying to enable members to utilize and connect with our traditional provider network. And this wasn't any provider network. It was certainly focused on a Medicaid population. It was very mission-driven providers, but despite our best efforts, there are still just limitations to that disconnect, to that model, because of the disconnect between the care management relationship and the providers. And so some of the roadblocks, Toyin hit on a couple of them, I'll add. The capabilities, I think there are no providers in our network who are uninterested in serving this population, but even the most sophisticated will say, I have not figured out how to under 65 duals and how to do it in a risk arrangement. Maybe on SCO, we're seeing some of that where there's an opportunity for the sophisticated providers, but not on the under 65 side. And so you add that to provider engagement, whether it's a relatively small population and timely access for acute needs. Think of behavioral health, transitions of care. We weren't able to leverage the network in the way that we wanted. And so the theory with CityBlock is, if you take a integrated care management and provider partner, they can flex to where the member needs. So that looks like Is it care management for a member who's really connected with their own care and in the network? Great. Is it an acute bridge moment where there's a transitions of care that's particularly at risk? And so you can have a behavioral health visit, you can have a primary care visit, and you're getting that member back into the network. And we're seeing some of this, and we knew that this would exist to some degree. There are some cases where a member will choose CityBlock as their longitudinal primary care provider. And we're okay with that because we know that the volume is really going to stay with our network in general. And if that member really is in need of something that CityBlock can deliver, then we want to provide that. And so it's a very unique model that they have to sort of fill this gap for a specialized population. And so when we realized we didn't have a competitive advantage to sort of fill in this space, CityBlock we think is the smartest folks in the room on this sort of area. And so we wanted to partner with them. But the last thing I'll say is I think anytime you're trying to set up something like this that's new, their ability to back it up with their balance sheet and take risk when they are providing such a small sliver of the traditional care to members, the provider care, went a long way. And I think it really shows the confidence that they have in their own model, and I think helped us get comfortably internally.
Great. Thanks, Mark. Mark, maybe to just a different twist on the question, and Toyin, you can add in as well. Now that you've kind of got the model in place and have been operating, how have you had to adapt in response to COVID-19 to support your members?
Sure. So I'll say for the existing population that we have in the risk arrangement, it's been really a great thing to have had CityBlock there. They've been able to maintain the ability to go into members' homes with the appropriate PP&E, and they have providers on the ground, and their ability to combine their virtual capabilities that they already had with their provider mentality really they haven't skipped a beat, which is to their credit. And I think we feel great that we have them in market. But what's going on with COVID really sharpened our minds and sort of accelerated our thinking and said, we've thought about this for the under 65 duals population, but there are at least some elements of CityBlock's model that make a lot of sense for other populations potentially, or high risk subpopulations within other product lines. Okay. And so we've stood up a fee for service model, really a pilot, where CityBlock is leveraging some of their capabilities to still be in the home during this time, as well as their virtual capabilities and we're proactively outreaching based on both data reviews on risk levels and on referrals to members within our MCO population now, our Medicaid MCO population, within our individual population, and for our under 65 duals members that weren't underneath the umbrella of the capitation. It's really early days, Brian, but we've seen examples where we can find moments where we can intervene and bring in a provider like CityBlock, and really, we think, deliver a differentiated network experience for our members.
Great. Thanks, Mark. Toyin, is there any additional things you would add related to how you've had to modify and kind of adapt the model on the fly, really, to respond to members' needs?
Yeah, absolutely. And just a thanks to Mark. It's no surprise that this has been a really collaborative and very enjoyable partnership to really work with someone who and a plan that really understands the value proposition and the opportunity to improve the outcomes for their members collectively. So I think going into COVID, even before we knew COVID was on the horizon, because our model has been tailored to populations that have historically been the hardest to reach, folks who have significant mistrust of the healthcare system, and also who have significant access barriers to healthcare. These tend to be the individuals who don't see their PCP frequently, who have struggles with transportation or with meeting their other social needs that create barriers to them accessing traditional fee-for-service, clinic-based healthcare on a regular basis and with the efficacy that they need. We've always built our model to be sort of omni-channel, to really meet people where they are. And we talk about that in our, from a philosophical perspective in terms of building trust, but also very practically and tangibly. Our care teams and our model is predicated on the idea that we go to our members. And that, for pre-COVID, often meant in person, in their homes and in the community. So most of our care was delivered, most of our care coordination was delivered in person, in the field, in people's homes, in community centers, accompanying them to their PCP visits and other visits within the network, as well as staying in touch as much as possible through every modality. And we deploy technology largely to allow us to stay in touch with our members through SMS, through telephone, through video visiting to some extent before COVID. And so it was pretty natural for us when COVID hit to ask the same question we'd asked before, which is what did we need to do in order to be there for our members and meet them where they're at a time when, you know, it was really increasingly more dangerous for people to leave their homes, at a time when people were increasingly more kind of terrified and mistrustful of going to the hospital, when people were increasingly more isolated, and when we had to really safeguard, of course, the well-being of our care teams. And so we pivoted very quickly, as most providers did, to virtual visits where in-person was not required. We scaled up dramatically our use of video, in particular as a modality, and started to prove that, I think contrary to common belief or lore, if you will, low income, dually eligible, Medicare, Medicaid, folks with disabilities can engage with technology if provided with the right supports. And so we're able to do a lot of our work virtually. However, and I think this is something that was really, really important to us, we recognize that no matter what you are able to do virtually, there are some folks for some needs who need in person, and they need it fast. And they need it from a provider that has access to their entire medical history. They need it contextualized with the ability to meet needs that are as varied as, you know, providing in-person medication reconciliation and education for somebody who struggles with intellectual disability and has problems reading, and also has, you know, 15 medicines that they have to remember. That is an encounter that requires an in-person interaction, usually with a pharmacist or with a clinician on our team, another clinician on our team, all the way through to our folks who were, you know, having shortness of breath, had COVID symptoms, were suffering from exacerbations of their underlying medical needs. We found that a lot of providers and specialists in particular within the network weren't able to meet people's needs during the height of COVID. And so we had folks who hadn't seen their nephrologist for 3 months and were, you know, struggling with symptoms that may be due to worsening of their kidney disease. The ability to go into folks' homes right away and to manage them in the home with a full complement and then some of the clinical tools that we needed was really important. And so to Mark's point, we, throughout our population, very quickly ensured that we had PPE in place from the very beginning, and protocols in place to enable our clinicians to get to people's homes. And we intensified that during COVID and beyond, so that we're able now, and in our partnership with Tufts Health Plan, have expanded that across a pretty large geography very quickly to have usually within less than an hour of a turnaround time, we can get a clinician into a member's home. They can, you know, check labs, put IVs in, give antibiotics, give fluids, communicate with their primary care doctor, manage their acute needs, in the interest of really keeping them safe and at home. And certainly has benefited us tremendously in our relationships with payer partners, where we are at risk longitudinally for the total cost of care and for quality outcomes for the population. And it behooves us in this time to make sure that our members are not going to suffer that sort of downstream excess mortality and morbidity as a result of unmet needs during this COVID time. It's really important to us that we can stabilize and continue to manage people's acute and chronic needs, as well as ensuring that at a time when COVID has really restricted their access to other services, that we're filling the gap. And that's been always sort of part of our model and our approach to meeting folks where they're at and ensuring that we deliver the care that they need when they need it.
Great. No, thanks, Toyin.
Brian, can I add one thing there? Just want to highlight one thing Toyin said. So even in this time, when Toyin just really articulated the value proposition for the rapid response during COVID, but she still mentioned how CityBlock is focused on reconnecting the member with their primary care physician and bringing them back into the network. And so it's a question I get asked a lot about, you know, how do they fit into the traditional network? I think CityBlock's particularly good, but I think this models in general and this concept of innovative networks, you're really filling this gap. You're filling this problem or this opportunity to be able to better extend that primary care physician's care for this member in some ways, and even in acute moments like this, still bringing them back to that network, because the member has a long-standing relationship with that provider, and that we have a network for a reason. And so it's really about extending that network and expanding the capabilities, rather than trying to sort of to get in the way or step in between, which is not the goal. So just even in this intense moment, I think it's important to flag that how Toyin thinks about it, and I think that's how we as Tufts Health Plan think about it too, because network providers are such an important stakeholder for us.
Yep. No, thanks, Mark. Makes sense. Maybe to build off that and add a bit, we've talked a fair amount about serving the needs of complex patients, specifically those in both Medicare and Medicaid. Sonal, do you have a perspective of how are we seeing similar types of innovations happening in the commercial sector?
Sure. We always say in healthcare, right, commercial follows Medicare. The point of the matter is that it's time that we also think about commercial innovation. And don't get me wrong, there has been a lot of innovation in commercial networks. So we have seen micro networks, right, in situations where a network is built right around hospital systems. And we've seen payer-provider collaboration or JV models that really accentuate that and keep everybody whole within that network, deliver both market share as well as obviously allow a petri dish of some sort to be able to manage care. We've seen pockets of direct-to-provider contracting, right? Now, the issue and the challenge with direct-to-provider contracting for large employer groups is you have to have geographic or regional density, right? Otherwise, it's hard to be able to orchestrate that. We've obviously seen narrow networks with ACA and the exchange population. But I think what we're talking about now with what COVID has accentuated, and then what's happening both on the purchaser side, where more and more employees and consumers are foregoing care because they haven't met the deductible, and a big proportion of today's employer-sponsored insurance is covered under high deductible plans. So it's a very different forum to really think about and reimagine networks. And payers have mostly taken the lens of you got an HMO network, you got a PPO network, you got a narrow network. But I think there's an opportunity to really think about, and especially what Toyin and Mark are highlighting, is a value-added network, right? Where the value-added network really focuses on not just an annual contracting cycle with the purchaser, but focuses on what type of care does the purchaser segment needs. And obviously, you and I are part of consulting. Consulting companies and their mobile population has very different needs in terms of how they access and consume healthcare to somebody who may be in a manufacturing facility or a different kind of industry. So again, bringing in that industry focus, focusing on different cost structures by segments. Obviously, what can you enable and do for less than 50 versus less than 500 and the large cases. So there is a lot of opportunity available. And if I had to frame it in just two ways, the easiest way to think about it, and I know you and I have talked about product innovation that's required, is how could you take network innovation, right, and tie and align both the provider side of the equation with how you pay providers, how you build networks, with the consumer side of the equation in how you align consumer incentives. And I think that type of alignment is required to really manage risk, right? So if there are instances of managing elective care, how do you cover that for that? Do you have a network that just focuses on elective care? And obviously with COVID, what got accentuated the most is that we all understood that the large delivery system business models are really built upon commercial driven or commercially delivered care and commercially delivered reimbursement to keep them whole. So we believe there's a massive opportunity to be able to reimagine network. And then the other part of reimagining network obviously always has to be with the lens of value, right? Are there opportunities now in these times to go and build and look at closer payer-provider collaborations? Are there opportunities to look at closer payer-provider collaborations with delivery systems or primary care communities in your marketplace that may be at risk or viability that I mentioned earlier? So those are some of the sort of the emerging themes that we're seeing. But to me, the most fundamental is if a payer can really figure out aligning both the provider side of the responsibility with the consumer and really deliver a more innovative network that's rooted with innovative products that are not built on an annual contracting cycle, I think that's going to be key. And we'll see more and more of that.
Great. Thanks, Sonal. And I think a big part of that often that comes down to data and what type of data you might need. Mark, maybe explain like how does data played into both shaping and executing on these strategies, and also different types of data than we may have seen before.
Sure. So data is so much of what Sonal's saying is just resonates. So much of building these networks and aligning them, the providers to the members, is defining the populations and defining the appropriate networks. But as we get, and data is going to be a critical piece of that. And so for a traditional commercial or individual market, you're taking the claims data plus all of the demographic data that you have and trying to build cohorts and build products that are interesting. For the under 65 duals population, the more specialized, we have care management, we have encounter type touch points, and how do we layer those on to further refine and specialize in these conversations? So I think intuitively we understand that, and I think we're working on it. But frankly and humbly, we're not there. As we get smaller and as we get more specialized, the conversation, especially in the complex populations, the conversation quickly sounds more and more like a care pathways conversation and a clinical conversation, which means that you're now constructing networks where you have to have a product specialist in the room, a contracting specialist in the room, and a clinician in the room to try to really think about how do you construct something that makes sense for a population that, even if it's hyper narrow, it still has to make sense for some group of members. That we've not cracked yet. So I would say that it is something that we are actively working on, both from a technology standpoint and I'd say from a human resource standpoint, making sure that we have the right folks in the room for those kind of conversations that we're talking about. But I will say that as I've seen us, work on this and try to work through it, I think more and more about how do we understand at scale and in some sort of analytical way what we're hearing from members, because we can have a million data points that are often passive, but stuff that we talk about with CityBlock all the time, which is how do we build holistic care plans for members that are member driven and member led, right? That's our goal here. We're just trying to enable members to make choices, to use the network that we're providing them. If we're able to pull that in, that's the best data points. And it's certainly aspirational, but just in the challenges that we see in, trying to just have reliable collection and synthesis of the data that we already have, I do find myself wondering a lot about how do we get even better at listening to the members and what they need, and try to structure that. Because I think if we could do that, that's the best data point that we can have, but it's also the hardest one to collect. So it's not a great answer, Brian, because it's a challenge that we have, but we certainly think a lot about it.
I think a lot of what you mentioned, Mark, and what is Sonal, you mentioned, Toyin, you mentioned, is a lot of this is also not traditional types of data. It isn't all just claims or encounter data or just clinical. A lot of this is getting to things to, well, what do you need in your life that may not be medical? Whether it's transportation, as you mentioned, Toyin, food needs, or if there's issues with isolation, and how do you identify some of that? Toyin, is there anything you would, given that's kind of key to the model you've built, how are you grappling with that, or kind of trying to do the best you can to kind of build out getting that information you need to serve those needs?
Yeah, absolutely. I think that's a key component of our model and our approach. And I think what is so interesting in this conversation from the plan's perspective is you have some of that data, and it sits in various parts of the organization, right, at the plan level. So, your actuaries and your med economists, they know who your high risk and rising risk populations are. They've already made a business case. They have bought some, fancy predictive modeling software, and they're looking at this data all the time because they need to understand what it means for their claims experience moving forward. Your sales and marketing folks understand the behaviors of subsegments of the population as they go out to kind of outreach and target and sell product over time. So you've got some of it in places, and then adding to Mark's point, that key clinical voice, which is what's the other piece that we can see, again, from the claims that helps us predict and understand not just what's going to happen to people, but what we need to do to intervene to change the trajectory for outcomes and to change the value proposition and to change the experience for members. So that's one key piece of it. And so that, as we think about data at CityBlock, it's pulling together all the information we already have from a kind of look backwards to predict the future perspective, as well as from the understanding of what your clinical diagnoses are, what do we have in claims, what do we have from pharmacy, to help understand what people need. And then we're actually going out and collecting in a first party, using our community health partners, who are the key component of our workforce on the ground, folks who are not clinically trained, who are hired from the communities we serve, who go out and ask questions about social needs, about access, about strengths that individuals have, about their history of personal trauma, about transportation and food and loneliness and exercise, that we then incorporate into this massive data set that gives us a real true 360-degree view of what is going on in a person's life and how that ties out to their outcomes over time and how we then tailor interventions. And so, from the plan's perspective, I think what you're moving towards is atomization. You talk about sort of atomization of networks. It is, let's take all of the data sources we have and think not just about segmenting from the perspective of, where do we sell our product or what markets do we enter, but also how do we then understand clinically what populations need from us in order to deliver the outcomes that we're hoping for them? And how do we incorporate the lived experiences of our members, either directly or by proxy, to Mark's point, to help tailor better what network provider would be best positioned to meet their needs? And that is, I think, a really important nuance. And then it tells us, one other thing that it does tell us and has shown us, is that actually the delivery modalities span lines of business. And so when you take this approach from a network perspective, you will find that there are providers, I would consider us one of them, within a network that can serve a certain type of member across your Medicare book of business, as well as your duals book of business, as well as your Medicaid book of business, as well as your low income commercial or your exchange population. There are commonalities amongst folks that if we take this approach, we can start to surface that allow us to meet a minimum threshold for coverage and for population, but also to serve the clinical needs on the ground of the populations that you're covering.
And I wanted to, if it's okay, Brian, just add one more thing to what she laid out. I think the issue in all the changes and why this has been so difficult, we're talking about, obviously there's data, but it's also this whole point of when you look at a typical network, you have to have panel density to drive any kind of practice level transformation. Now, if you bring a network that's all they're going to do is take care of that particular patient, you immediately and automatically on demand bring that panel density. But when you look at a general body of a payer network where the same provider is serving Medicare lives, Medicaid lives, and duals, and they have also obviously the commercial lives, you need more of this, right? You have to be able to share this data. And what we have seen in our analysis and working with our payers is it's always the 80-20 rule. Many of the times you see those 20% of the primary care providers that's really driving 80% of traffic to specialty care and other places. If you can really right size it, so they really end up going and referring it to the high providing network, or they really end up focusing now is with an e-consult for a specialist, then really going to the specialist and meeting them for XYZ, it could really change the dynamics of affordability and care. And obviously, if you can add on to it with data, as Toyin said, to predict the hospitalization, because you're always connected with that patient, it starts becoming more clear. So I think data and technology is definitely going to be key to it.
So I think with that, you mentioned the concept earlier, Sonal, related to alignment. How do you align it, both incentives? How do you align both providers and consumer incentives around that? We had the discussion around data, a big part of this as well. Can you get enough data across the different silos to actually understand what's happening and what the needs are to help kind of with the shaping and so forth? And those are just some key lessons learned. Maybe as we look to wrap up here, wanted to see both Mark first and then Toyin second. Are there any other key lessons learned that we haven't covered that you would suggest to other health plans that are looking to move into, or just as they think about networks and new care models?
Sure. The quick one I would share is, what what we're talking about here from a theoretical perspective about how you bring in an innovative solution into your network with a partner that is neither a care management vendor, so to speak, nor a traditional provider, the amount of, selling is the best word I can think of, but it's more, the amount of conversations I've had both internally at Tufts and externally with federal and state regulators, plus providers in our network, plus members, because we have an advisory council, trying to explain what this is and why it works. There's a pretty big learning curve, and just because it is new and innovative. And I would not underestimate the amount of time that you'll spend having these sort of conversations. I've used the term neither fish nor fowl more times than I care to remember, but it really has been, and it's taken that to get some buy-in. So that was a little surprising to me, which it really makes a ton of sense when we talk about it in this group. But as you go to implement and as you go to execute, there's a lot of stakeholders where you'll find yourself really bringing them along on a solution like this and a partner like CityBlock.
Yeah, I would just echo that, Mark. I think making sure that you have the right stakeholders in the room for the conversation is key. And to your point, there are a lot of stakeholders. I think the thing that has always served us well is tying this to clinical experience, and so making sure that there are clinicians in the room for these conversations to help overlay what we're talking about from a theoretical and policy perspective very much to the ground of like, what does it actually mean for the humans that you are serving and for the outcomes that you're trying to achieve? Because it is so critical to recognize that unlike most solutions that one might go to purchase to help manage, MedX over time, or to help manage spend over time, or to help manage quality over time, this is ultimately about finding human beings, building trust with them, figuring out what each person needs and meeting those needs, and helping to convince them to change their behaviors over time. Like it is actually that simple. The people, the stakeholders that need to buy in, where the dollars come from, what success looks like, that stuff takes a ton of time. But if you can't articulate that simple arc, which is we have a problem that we're trying to solve for, which has got a lot of members that we're financially and morally accountable for, many of whom have needs that are today not being met effectively through all of our best interests and intents and hard work. And we've got to get them to a place where they are effectively managed with great outcomes and wonderful satisfaction. Like, we got to tell that story. And then you have to figure out which people in your organization, which stakeholders are responsible for what part of that work today, who need to get bought in over time. And the importance of storytelling and the importance of stakeholder buy-in and alignment cannot be understated. And so I hear that tremendously. And that's why we get to build such great relationships, I think, through the process of trying to solve these problems together, because we've had lots and lots and lots of conversations to make sure we're on the same page throughout.
Oh, that's great. I mean, that point of just remember that this is put people first. What are those particular needs, and then how do we solve it, and then work backwards is great advice. Great. So maybe just in quick recap, I mean, Toyin, I like how you started this. If I go summarize key things, it really starts with, as we said, putting the person first and thinking about the different diversity of needs of all your members, using that as a starter, and then working backward. And with that, you'll get to, like what you were mentioning, Sonal, that will kind of naturally drive to the atomization of networks and just different ways of putting those needs to provide those services. So with that, one, I want to wrap up and thank AHIP for the opportunity for bringing us all together for this discussion. And specifically, thank you to our panelists for all that you're doing out there, as well as joining us to share that with other health plans and others in the network. And then thank you all as well for joining for the discussion. Thank you.